Welcome to the latest episode of Open Access, Open Mic, the podcast with the Apt Foundation. The Apt Foundation is here to help employers, communities, and families care for people who may be living with opioid or other substance use disorders, serving the Greater New Haven community through an evidence-based open access model. Get in touch with us to find out more at aptfoundation.org.
Welcome back for another episode of Open Access, Open Mic with the Apt Foundation. On today's episode, we are joined by Apt CEO and President Lynn Madden and our very special guest, Dr. Judith Feinberg. Now, Judith is the Professor of Behavioral Medicine and Psychiatry and the Professor of Medicine and Infectious Diseases at West Virginia University. Now, to list all of her accolades and career achievements would probably take an episode in itself, but her work spans infectious diseases, public health, and harm reduction. Dr. Feinberg joined West Virginia University School of Medicine in 2015 after extensive work in HIV clinical research in Ohio. It was there that she established the Cincinnati Exchange Project, the state's first true syringe services program. While at WVU, she developed a research program to evaluate and implement solutions at the intersection of the injection drug use epidemic and infectious diseases. Judith is the only person to have chaired both the HIV Medicine Association and the American Academy of HIV Medicine. She has also served on federal and state committees dedicated to HIV/AIDS, hepatitis C, and the opioid epidemic. Another connection of note is that Judith works with both Lynn and Rick Altice on the Birch Project in West Virginia. Judith, if that's not enough for you, I don't know what is. Welcome to Open Access, Open Mic, the podcast.
Thank you for having me.
Let's kickstart this one with, can you tell me a little bit about what originally drew you to infectious diseases as a speciality?
Well, it's like solving a mystery, and I love mysteries. I like reading mystery novels, so you get these cases where people have bizarre symptoms and you have to figure it out. So it's really like following all the clues. It's totally not like other parts of internal medicine where you poke needles into people and biopsy things or snake catheters into them and do things to their heart. It's all mental, I guess one way to put it. But it's all like solving a problem. And I just like that. And then because I started my training at the outset of the AIDS epidemic, of course, I got sucked into HIV, which was the most puzzling puzzle of that time, the early 80s.
Yeah, for sure. It was quite a time. And I know we were talking earlier before we started recording, that your work in that field is quite pioneering. Lynn, would you like to jump in there?
Yeah, thank you. And thank you so much, Judith, for agreeing to join us today. We'll just say that, yes, my understanding of Dr. Feinberg's work is that it was quite pioneering. And then after that, what would have been a full career track for many people, Dr. Feinberg made the decision to begin to think about the intersection of substance use disorders and HIV and other infectious diseases, particularly there in West Virginia, which I'm sure she'd like to speak to. This is a way of understanding the HIV epidemic and the harms of substance use disorders that is relatively unique, making that overlap and understanding the intersection and treating people and systems in ways that allow both of those sets of processes to be identified and to help individual people, but also to just have a huge impact on overall public health.
You've done some incredible things, Judith, incredible things. But I'm just wondering was there a defining moment in your career that kind of shaped your focus on public health and harm reduction?
Well, the public health piece started with HIV because it was stigmatized and really physicians had to be patient advocates in order to get anything in the system to move, including getting the federal government to devote resources to investigating it, but also just to, be able to keep your patients from being thrown out of their apartments and being fired from their jobs. I mean, it was a really pretty terrible time. So the public health aspect's been there from the very beginning. And I think it's kind of telling that, right, infectious diseases was like the beginning of public health, right? Finding that you could, typhoid Mary, right? and the water pump in London. I mean, it's been a central piece of public health from the very beginning. The harm reduction part came more recently when I was faculty at the University of Cincinnati and started seeing too many cases of endocarditis, which is this terrible heart infection that can be fatal. Too many cases. So that was unusual in itself, and quite unusual was the fact that these were individuals who were transferred from small outlying community hospitals in Appalachian, Ohio, to the University of Cincinnati, because if you have endocarditis, you need to be cared for in a place that can do cardiac surgery. You might need an emergency valve replacement. You can't do that in a 20-bed rural hospital. And that was weird. At that point, I'd been in Cincinnati for 10 years and had never seen anybody transferred in from the Appalachian Southern Ohio. So Appalachia actually ends at the border of the county where Cincinnati is. So our eastern suburbs are technically speaking in Appalachia. And then, you examine people and you see that they had track marks, and it was clear that they got endocarditis from injecting drugs. And this was really new. So the northeastern corner of Ohio, where Cleveland is, had an established opioid heroin epidemic for many years. But Cincinnati, which is in the southwest corner, had never experienced this. And so I knew something was up. Before I came to Cincinnati, I was at Johns Hopkins. And Baltimore, of course, is an old center of heroin use, what I call the 20th century heroin epidemic, as opposed to the 21st century opioid epidemic. Our AIDS ward, which was 21 beds, at any given time, 10 to 20% of the people who happened to have HIV were really in the hospital because they had endocarditis. So I knew what this signal meant. I knew if we started seeing people with endocarditis who injected drugs, that they would clearly be vulnerable to getting HIV and hepatitis B and C, because they're all transmitted from injection drug use. And I knew that we had to do something. And at this point in 2005, the use of syringe exchanges, which had started in the early 90s to counter the HIV epidemic in places like New York and Baltimore and Cleveland, was well established as a way to counter those harms. And so I started agitating for a syringe exchange project. And it was tricky because Ohio law wasn't very friendly to this. And it took a long time. In fact, it took 9 years of continued advocacy, finding local organizations and people who supported this. And it was like reliving the early years of HIV again, because drug use is just as stigmatized as HIV was. I encountered terrible bias and unbelievable responses from people who were like, well, just let them die. I'm like, no. That's not the oath I took. I didn't take the just let them die oath. I took the oath. It's like, got to save as many lives and make people healthy and keep them healthy as I can. So it was a pretty uphill battle, but we finally got, by Ohio law, the local permission. And then it took another year, because this is the way the law was structured. First, you needed permission from the public health authority, whoever the regional public health authority was. And then you needed permission from the regional law enforcement. And it took another year to convince, the Cincinnati Police Department that this was something that should be done and that they shouldn't arrest the people coming to and from. So it was a 9-year effort, but it bore fruit and it was very exciting. And we bought an old RV, beat-up RV, and transformed it into a mobile syringe. Well, it was, a syringe exchange, but really we did the full complement of syringe services. So in addition to giving people sterile injection equipment, we gave them all the other stuff you need, the sterile water, alcohol swabs, male and female condoms. We signed people up for Ohio Medicaid. We did warm handoffs when people came to us and said, I need help. I can't do this anymore. We had MOUs with local treatment organizations. We actually drove people to their appointments because we discovered people were so freaked out that even when you called and made an appointment with them, they would not show up either because they didn't have transportation, or more commonly because they were just freaked out and worried about, having being stigmatized and having a very negative reception. People who inject drugs don't really feel kindly about the healthcare system because the healthcare system isn't kind to them. So then we wound up driving them and sitting in the waiting room with them until their name was called so that they had that support. And it really made a difference. It was really encouraging and heartwarming to be able to do that for people. And it very much, as I said before, was parallel to the advocacy work that I had done when my sole focus was HIV. And what drew me to West Virginia was the 9-year struggle, including many trips to the Ohio State House in Columbus, had left me a little beaten up. And in 2014, the then governor of West Virginia said in his State of the State address, heroin is West Virginia's #1 problem. I thought, yes, I'm going there. I'm going to go there because there at least the governor acknowledges that it's a problem and we're going to do something about it. And then a close friend and colleague had already been at WVU for a year. And she said, you want to come here? I said, yeah, I want to do something about this. And that's the story. That's how I wound up in West Virginia.
That is quite remarkable. They say that most people run away from a burning building, but you're one of those few, and you truly are a rock star who runs to it to try and be part of the solution. Kudos to you.
Some people might say it's a bit foolish, but to run toward a burning building. But yeah, I guess I have that.
In this context, you save lives by doing so. So, bravo to you. And it kind of leads me on. There was lots of things you just mentioned that we're going to actually come back to, stigmas, barriers, etc. But one of the things that you've kind of led me in beautifully to is how has your work evolved since joining West Virginia University?
Well, it's really been a fascinating experience. I'm an urban person. I'm a New Yorker by birth. I have lived and worked in many large metropolitan areas. I had never focused my work in a region that was rural. So I learned, first of all, a great deal about the obstacles and challenges of delivering healthcare in a rural environment, especially a rural environment that's really poor. I mean, West Virginia is a really under-resourced, poor place. As the coal industry has crashed, there's really nothing there that took its place. And although it's very beautiful, it's a mountain from one end to the other. That's also an obstacle for doing things like laying cable. It's not like it's Iowa that's flat and it's easy to lay cable, but everything's a mountain. If you want to build, let me put it this way, if you want to build sort of a modern strip mall in West Virginia, you have to blow off the top of a mountain because there's no flat land there. Wow. So, it's not only is it poor, but it's also very behind in terms of, modern 21st century communication. Because its internet access is intermittent and sparse in some areas. It's okay in the major cities and towns, but as you get further and further away, it's more and more difficult. So, people have dial-up or they don't have any access at all. So that was the first thing, was learning how to navigate in a rural environment and to do research in a rural environment. So all my research had always been done in a completely urban setting. Then the second thing was to, the same obstacles that you would face anywhere, which was tremendous stigma. And that continues to amaze me because in 11 years, I have not met a native West Virginian who does not know someone in their family or who lives next door who's been caught up in the 21st century opioid epidemic. It is so widespread that it's an experience that everybody has. And you would think, given that these are people's family and neighbors, that there would be more empathy, I guess is the word, but more understanding at least of how difficult the problem is. But there is a tremendous stigma there, as there is everywhere else. So, that's another obstacle that you have to overcome. And other kinds of obstacles are that, for example, when you talk to people who have substance use disorder from injecting drugs and talk to them about, are they interested in medication to prevent getting HIV, the uniform response is, are you saying that I'm gay? And I say, no. Did you know that you can get HIV from injecting drugs and sharing the equipment or the drug? Nope. People don't know that. So, even the population at risk that we're trying to reach and help, one of the obstacles is they're not well informed. And that's been another piece of the puzzle that you have to deal with and figure out a way to overcome.
And Judith, I wonder if you would comment. I mean, West Virginia, just from an epidemiological point of view, is really a hotspot for the issues related to the harms of opioid use. But I wonder if you would comment apropos of your previous remarks about people not really being aware of the potential harms of injection drug use, for example. Comment a little bit on that intersection. I think that's a phenomenon that goes throughout our healthcare system as well as the general population. A person is not their diagnosis, right? And it's possible and likely that a person has multiple clinical medical issues, particularly as they move through life. But talk a little bit about that. I mean, why is it so important to think in a more holistic way about the person before you?
Now, that's a great question, Lynn. So thank you. So substance use disorder is a chronic relapsing brain disease. And it's incontrovertible that is the case. And there's just a ton of data that support that, as opposed to you're a person of poor character or a person of poor morals or a person of poor willpower or somebody who doesn't get down on their knees and pray enough. And when people inject drugs and are vulnerable to the things that injecting drugs can risk, like hepatitis B, hepatitis C, HIV, then, people acquire multiple chronic conditions that are all part and parcel. They're all hang together. And typically in the past, these things have been sort of dealt with in a siloed way. They're kind of separated. There are people who are addiction care specialists who deal with the substance use disorder. There are people who deal with the infections. And really, this all needs to be integrated because that person is a whole person with multiple problems. And that's really the nexus of the work that Lynn and I are doing with Rick Altice in West Virginia. Not surprisingly, we discover that, for example, when you cure someone's hepatitis C, which is miraculous that we can cure it. It's the only viral infection that you really can do that for. And you can cure it in as few as 8 to 12 weeks of once a day therapy, which is even more remarkable, and with almost no side effects, which is even terribly more remarkable. And you do this, and people come in and they get their confirmatory blood test that says they've been cured. They cry. These are grown men. They cry because it's so spectacular. But what we have learned from doing this is a couple of important things. One is that people become more committed now that something bad that could lead to liver cancer and cirrhosis and death has been fixed. They're like, oh, well, maybe I'll have my blood pressure checked. Maybe I'll get a screening for cervical cancer, and people start to take better care of themselves. So that's one thing. But the second thing that I think is really terrific is the emotional meaning of this, which is that people start being treated like people again, not like their diagnosis, not like they're an addict and they're a bad person. No, they're a person who has these problems. We cured one of them. We're treating the others, and people become, their self-efficacy and their feeling about I'm a worthy person, I'm worthy of being healthy is very, very important. And the third thing that we've learned is that it reinforces people who are in recovery when this happens. Now, we can treat people who are still injecting, and we do. But people who have entered recovery, and we have discovered that, dealing with their other medical issues has really reinforced their commitment to sobriety. Like, I got sober, my hepatitis C is gone, I'm taking medicine for my HIV, I'm going to live to have grandchildren. We've really seen incredible benefits that are both individual health, public health, but third, and I think from a human perspective, most important is a sense of worth as a human being. I mean, we all need that, right? You can't wake up in the morning and think, I'm a schmuck,
Absolutely.
and nobody likes me and, and my family hates me and I'm a bad person and it's all because I didn't do X, Y, and Z and, all the negativity that comes with having the diagnosis of substance use disorder. And that is really fantastic to witness and experience and share with people. It's really what being a doctor is all about. Yeah. It's not just the magic of the right blood test answer. It's like the people are encouraged and satisfied and happy. And, really, can't get better than that.
Nope. You're spreading hope, boosting self-esteem, self-confidence, and reminding people this is not a moral failing and treating it accordingly. Incredible. You mentioned then the work, obviously, you've been doing with Lynn and Rick. That's the Birch Project, isn't it? Is there anything you'd like to tell me a little bit about that?
So that is a project where we are working with about 15 primary care clinics across the state. Most of them are federally qualified health centers, which is how West Virginians, especially rural West Virginians, access care. There isn't much private practice in these areas, and FQHCs by law have to accept everybody who, as a patient who crosses their threshold. So they can't say, oh, we're not interested in you. You have substance use disorder. And even in these places, which, are kind of the only healthcare in the area, still the treatment of these problems was siloed. And so we are helping them through coaching them through change projects. We are helping them learn how to integrate the care for these individuals, and not only integrate the care, but also, the federal public health recommendations now are to screen everybody who's an adult at least once in a lifetime for HIV, hepatitis B, and hepatitis C. But those recommendations are not exactly commonly followed, and not just in rural West Virginia, but everywhere, And when we encourage and show these primary care sites that screening is a really key point of entry into care, then that's something they haven't done before. And that really improves the healthcare of people. And then this project is, every site deals with its own circumstances, its own situation, its own administration, its own benefits and deficits. And so what people need to do to make things better is variable. And people have approached this in different ways. Some people have started a treatment for substance use disorder, which they had never done before. They had outsourced it. Now it's on site. Other people have done a better job of integrating the infectious disease and substance use care. Other sites have, there's just a lot of different ways to approach this. And people have done this in different ways, but there's certain commonalities. And so we have these learning collaboratives twice a year where we get the people together from all these sites and they learn from one another, which I think is actually part of the secret sauce. It's one thing to have all these experts, me with my New York accent, even though I'm at WVU, and Lynn and Rick coming from Connecticut, and having all these people sort of descend and say, well, try it this way. But when they hear from their peers, wow, this worked, and this worked in town X, then they think, well, it worked for them, and we have kind of a pretty parallel problem. Let's try that. And so we get this wonderful cross-fertilization and sharing of solutions and ideas. And I think it's worked so well because it really is people facing this problem in their everyday work who have figured out ways to improve that work, the efficiency of it, and the number of patients that they can see and the number of patients they retain in care. And that's really crucial. It's okay if people cross your threshold, but if you don't keep them in care, you haven't really accomplished a lot. And, I just think it's a better modality than having people from universities come in and say, do this, we think it's a good idea. I think when they see that it works in their environment or a similar environment, that's it. And I have a mentor, a younger faculty member at WVU who's a pulmonologist, and his expertise is sleep apnea. And he was so impressed by the programs that we have to teach primary care clinicians how to take care of HIV and Hep C and Hep B, that he said, I'm going to write a career development award, which he got from NIH, to do this for sleep apnea. So, it's not like there's the substance use disorder and infectious diseases are only the chronic problems in rural West Virginia. There's a lot of, we're number 1 or 2 for morbid obesity, which is what leads to sleep apnea, and heart disease and diabetes. All these things are tied into sleep apnea. And now, we're expanding that model outside of, just the area that Lynn and Rick and I work in. So I just think it's a wonderful approach. And I've learned a great deal from Rick and Lynn about how to do this, because this is not something I had previously done.
Yeah, I think it's just to piggyback on that. I think it's so critical to keep in mind how hard it is for a person with a drug use problem to come and tell someone, right? So that is a really stigmatizing place to be, both for yourself, because many people with drug use problems tell us that they're ashamed of themselves or that they don't feel worthy, as Dr. Feinberg has said. But also systems and organizations often treat individuals with drug use problems in ways that reinforce that. So if we try to consider the human aspect of how difficult it really is to take that first step, then purposefully looking at that touch point, wherever that turns out to be. So we're talking primary care in the moment, in rural environment. This exists all over the United States. If you've made that first step, we should find ways of making sure that your other healthcare needs are addressed, that you understand that they exist, through mechanisms like screening or easy access, right? That you're valuable, you matter. And by the way, there's some other things going on in this constellation of drug use that it might be useful for us to really check out with you, right? So I think it's as well as being clinically appropriate, it goes back to Dr. Feinberg's point about what it's really like to be treated as a person of value, right? We know things. We know that it's likely that you've been exposed to an infectious disease if you are in fact injecting drugs in your lifetime, even if that's not recent. So this is an attempt to sort of re-engineer not only the system, but the thinking of the people who work in the system. Like this, it's not hard to do the screening. It's just not been typical. Right. So this idea that they, in fact, can contribute to the outcomes, the better health outcomes of not only the individual, but the community at large through pretty simple shifts in clinical practice, I think is part of the whole resonance of the work. And what's coming out of Birch is easily replicated in other primary care settings all across our country, which I think is terrific.
Right. We have focused on West Virginia, and it is a rural state whose healthcare problems, as I said, are exacerbated by the lack of resources in very poor rural areas. But there's nothing that says this wouldn't work in urban environments too, where people are also sometimes disadvantaged and healthcare access is not easy. And I agree. I think the work that we're doing is broadly applicable. Right? Over 100,000 overdose deaths a few years ago. We have a tremendous problem in this country that is now sadly being complicated by not only more potent synthetic opioids all the time, right? You can't even get heroin anymore in West Virginia. It's like, forget it. But now also the infiltration of amphetamines, which complicates things because methamphetamine use disorder is not as treatable as opioid use disorder. We have medications for opioid use disorder. We don't really have yet targeted medications for people who struggle with stimulant use disorder. So, the fact that this is broadly applicable, I think is just really important. It's important at a public health level nationwide.
I couldn't agree more. And it's really interesting that the change in what we're dealing with and trying to keep ahead of the curve it sometimes feels like a never-ending battle. And that kind of brings me on to perhaps the biggest challenge I've found within this work, which has been the work we've been doing with Altice, is the barriers to care and specifically the stigma around it. How does that, or has that presented for you, and what do you try and do to overcome it? What are some of the biggest, I guess, misconceptions people have about harm reduction strategies?
Well, I think there is this enduring misperception that substance use disorder is a personal failing and therefore that individual's fault, as opposed to the fact that for whatever reason, when they first tried this, which, a lot of young people experiment with a lot of things. This is not a unusual or rare event, right? Your brain isn't fully mature till your late 20s. So, anything before that risk taking is kind of like, hey, why not? It's just once. And it's very hard to overcome that and have people see that it very rapidly, for some people, not everybody, thank God, but for some people, this really becomes a chronic disease. It becomes substance use disorder. We are sadly a very moralistic country, and lots of other, first world, well-resourced countries don't really deal with substance use disorder the way we do here in the United States. We have a very moralistic kind of Puritan concept of individual responsibility for disease and on some level, a lack of empathy, a lack of sympathy. And you know what? It's like there, but for the grace of God, go most of us, right? At any sort of difficult moment in your life, if you had made a bad choice, that could be you or someone that you really love. And that's, I think, an enduring problem. How to fix that? How to overcome that? I've been thinking about that for the 40 years since I started in HIV, and I wish I had a clear answer. I mean, you want to say that education makes a difference, but that hasn't proven to be the secret ingredient. And as I said, you can't meet a West Virginian who doesn't know someone who has struggled, and you think that personal connection would convey empathy, and it might convey empathy for that person that they know, that it doesn't necessarily convey empathy for all of the people who are struggling with substance use disorder. I mean, let's face it, substance use disorder is a difficult problem that leads to a lot of social misbehavior so that people can get access to the drugs that they physiologically now need to keep from going into withdrawal, which is very uncomfortable and which people avoid at all costs. Families have been burnt by family members who have taken advantage of them. So, it's not easy. I don't know if Lynn's got a better answer than I do, but I think about this all the time, and, I don't have a clear pathway to fixing that problem.
Yeah, I think stigma is so difficult, and it manifests in so many ways. It manifests structurally. It's hard to get into treatment. Sometimes it's hard to find a treating provider, for example, who's even nice to you. It can manifest in ideas about, that you don't care about yourself, that you don't care about others, that it's a disease where it's okay to actually abandon the people that you care about and love. I think stigma has its roots in lots of places, as Dr. Feinberg was saying. But one of those places, I think, is fear. That people are afraid that it will happen to them, or that somehow they are, that they're not strong enough, or you should be stronger, so there are all kinds of, I think, at some level, kind of uniquely Western ideas about how people should behave. So stigma isn't equal. Right? There's more stigma, for example, against women with substance use disorders. There's more stigma against women with children who have substance use disorders, right? So stigma's not equal, and it has to do at some level with what we perceive about deservedness in our culture. It is really complicated, and that one of the ways of thinking about how to mitigate it is simply identifying how the structures of our society that we intend to help people may in fact be creating barriers for them. So that's a way that one can think about how to mitigate structural stigma and eventually change people's minds. And I can give a quick example of this. We used to be in a space where if we made an appointment for a person with a substance use disorder to come in and be evaluated, and those appointments average about 30 days across our country out into space. So if I call today, I can go sometime in May. And if I don't show up for that appointment, generally speaking, it used to be believed that I wasn't ready, that somehow I would have made it to that appointment. But the reality is that I'm too sick. If I have a substance use issue and I can't see someone to help me for 30 days, then I'm going to keep using drugs. And as I keep using drugs, I'm still experiencing those deficits that go along with using drugs that include, poor organizational skills, for example, lack of motivation, which is a symptom of a substance use disorder. What we learned when we shrunk time to treatment, and we've seen this in a number of places that Dr. Feinberg and I have been coaching, when you shrink time to treatment, people actually show up, right? So you can measure this idea that somehow it was about motivation by shrinking the barrier, and it works. So when you shrink time to care, people come because they can hang on to their motivation for that short amount of time, but also because it sends a message to them that they are valuable, that their problem is worth your time, right? So I think that there are ways of thinking about stigma that go beyond trying to understand it and really try to mitigate it in these structural types of approaches.
Yeah. Question from me, if I may. Judith, what policy changes would make the biggest difference right now, 2026? You've seen so much, but what policy changes would most help?
Well, at both federal and state levels, access to health insurance that pays for treatment is quite critical. And the current administration has really damaged that safety net so that by rates, West Virginia has the highest proportion of people in the country who are Medicaid dependent. And as Medicaid support, federal support is weakened, that means that there's people are just not going to have access to care. So, I think that is, access to care, I think, is a very key thing. I also see in West Virginia and scattered throughout the country, because this is pretty variable by state and area, a real retreat from the principles of harm reduction. So that, 4 or 5 years ago, we had 16 syringe exchanges, some of which were syringe service programs that did more than just give people sterile syringes. Now we have 6 or 7. Then there was a bill this session to outlaw it. So we're moving in the wrong direction because everything you do to criminalize this disease makes it harder for the people who struggle with this disease, to get care. And it's a disease. How can you criminalize a disease? Would we throw everybody in jail who had diabetes because they went to McDonald's, and got French fries and then, ice cream afterwards? There's something about this that is such a logical disconnect for me. The concept that you criminalize something that is a diagnosis just seems strange. And I will tell you what, my first level of training is an internist, and, there are people you admit and readmit to the ICU for chest pain after chest pain and heart attack after heart attack or diabetic coma after diabetic coma. And we never say to these people, you're a bad person. We say, you should eat better. You should take better care of yourself. But we never say, you're bad. What you're doing is wrong. You're bad. And you know what? We're not going to take care of you anymore. We never say that. Just bizarre to me that substance use disorder somehow is in this different universe where we can say you're bad for having this disease and we're going to punish you for it, as opposed to we're going to help you with it. So, those are the kinds of policy things.
It's not bizarre. It's absolutely infuriating.
It's maddening.
It kind of leads me on nicely to the last couple of questions from me. And this one's perfect. It's just planned this way, honestly. But what keeps you motivated in such a challenging field?
Well, I love seeing people get better. It's the primary, motivation to become a physician, right? Is to keep people healthy or get them healthy. And it's so rewarding to, my God, curing hepatitis C, really? These are people, a proportion of which would have gone on to get cirrhosis and liver cancer and die from it. So, seeing people get better is so rewarding. I have to tell you that, at a personal level, it's really a thrill. It's really a good thing. At a public health level, when you realize that this is something that affects, society and a great many people, not the people just sitting across from you as your patient, but, when you think about society as your patient, it's rewarding there as well. These are diseases that are passed from human to human. If we could stop giving hepatitis C and HIV to one another, they would go away. You don't get this from animals or toilet seats or mosquito bites. And so, you really, along that path, there's improvement in individual health, but ultimately you could really make, the world a much better place. And I think that's at the heart of it.
You're full of hope. It's fabulous. And it's not ebbed in any way. And I was just kind of thinking, I'm going to tack this one on for good measure, but what advice would you give to medical students or young professionals in the field who are interested in public health?
It's so rewarding. I want more and more people to do one of two things, to either formally get trained in public health and enter public health as a career. Certainly most people who go to medical school want to treat people, want to be healers. And it is really, really critical to see that there's the patient across from you, and then there's every connection that patient has in their family and in their community, that treating them as human beings and offering them the care that they need, has a ripple effect and just, improves our world, the world around us, to a great extent. So I would like to see that medical students and nursing students and, other health professionals actually have contact with the people that Lynn and I help take care of, and see that these are human beings in need of their care, as opposed to some sort of abstract concept. I would love to see that happen as part of their early training, so that, they leave their training ready to, to provide the assistance that's desperately needed in this country. If you think about that, right, over 100,000 people died from injecting opioids a couple of years ago. That's a lot of human beings. We could do better. We should do better. We must do better.
Can't think of a better way to end the podcast. That's like probably the best soundbite you're ever going to get. Judith, it's been an absolute privilege.
Well, thank you very much.
Thank you for taking the time to listen to this episode of Open Access Open Mic with the Apt Foundation. If you have enjoyed this episode, search Open Access Open Mic wherever you get your podcasts from. A special mention to Hancock Pharmacy, who have been serving the Connecticut public since 1959. The Apt Foundation values their help in serving our New Haven area clients. Their Long Wharf location provides medications for treatment of substance use disorders by prescription from our primary care doctors, who are also trained in addiction medicine. Visit HancockLongWharf.com.